I've had bariatric surgery. I had a gastric sleeve, and I would like people to know that it is not like the commercials. I don't think that you go into surgery and then, like a week or two later, you're holding up the big fat pants and, going, I had bariatric surgery and look at me today. These are my fat pants and now I'm skinny. That is not what happens. Um, for me, I knew that I was never going to be like a skinny fashion model. I'm too old. I'm not never going to be that person. But I thought that it was one more tool in that toolkit that was going to help me get healthier.
This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's so good to see you two.
Hello.
All right, this is a topic near and dear to Andrea's heart. We're talking about bariatric surgery today. This is kind of a controversial thing, isn't it, Dr. Cooper? Because any surgical fix to, obesity seems to have a bit of a stigma attached to it. But let's kind of set the playing field for everybody. What exactly is bariatric surgery?
It's so true. There is often a stigma attached, which doesn't really make sense because it's a medical procedure, just like, any medical procedure. But bariatric surgery started out many years ago in the 1950s as a way of triggering weight loss, basically, way of treating obesity. And at that time, scientists and medical professionals thought that the key to it would be to divert the fuel, the incoming food, away from the small intestine where we absorb all of our nutrients. And so these surgeries were called malabsorptive because they blocked the absorption of nutrients from our intestine. And they got to be pretty radical surgeries where they blocked a large percent of the intestine. And over a period of time, they saw kind of high complication rates, and they started to change the procedure to include a process of shrinking the size of the stomach and blocking the intestine, a combination, which would be the gastric bypass. If you've heard of that, it's very popular even today. And the gastric bypass is also called the Roux-en-Y gastric bypass, RYGB. And that consists of a procedure of shrinking the size of the stomach as well as diverting away from the small intestine the incoming food. And so it combines malabsorptive processes with what's called restricting the size of the stomach. And so that was kind of a newer way of treating this. And then over time, they started to realize that just the restrictive portion without diverting the food away from the small intestine, without the malabsorptive part, was also very effective and with less complications and less long-term complications. And so that would be referred to as the really popular procedure today, which is the VSG, vertical sleeve gastrectomy. And that is the procedure Andrea was talking about that she had. And that is today the most popular procedure. And there are others now where it's advancing even further.
So, Dr. Cooper, when you have those things put around the stomach, what's the effect of that? I get the bypass of the small intestine where all those nutrients are absorbed. But what happens when you restrict the stomach?
Well, at first, everyone thought that the way that these surgeries would work is to make people eat less food. That's what they thought. they thought, well, they can't stay on a diet, so let's do this procedure to either prevent them from absorbing the nutrients or prevent them from eating as much food by restricting the size of the stomach. But then they discovered that the beneficial changes of the surgery occur within like 48 hours after the surgery. So the beneficial hormonal changes
Wow.
that are happening start within like 4 days of surgery, being pretty dramatic. And so they realize that it isn't about eating less is not really where the benefit is. And so now they're trying to change the name of these surgeries from bariatric surgery to metabolic surgery. So the way we describe them now should really be more metabolic surgery. And so, in particular, the VSG procedure, it does shrink the size of the stomach by removing the lower portion of the stomach. So you take, they literally go in there laparoscopically and remove that lower part of the stomach. But the lower part of the stomach is also where the ghrelin is manufactured. Like 85% of our body's ghrelin is produced there. And as you know from previous episodes, the ghrelin is the you know, kind of gremlin. A lot of our patients call it the gremlin, but it is the hunger hormone that really blocks satiety. And it also kind of jacks up your cortisol levels and it slows your metabolism down. And so part of the surgery, that's not the whole way it works, but part of it is that it removes the ghrelin producing area. So it gets that out of the way. And it also, by shrinking the size of the stomach, it accentuates what are called the stretch receptors. And those stretch receptors help activate our body's natural beneficial gut hormones that we're talking about that you also get from some of these new pharmacology medications, GIP, GLP-1, you've heard of in some of these new medications. Like they're not actually that new, but they're the newly popularized medications such as Saxenda, Wegovy, Ozempic, Mounjaro, the body's natural hormones can be accentuated also through the shrinking of the size of the stomach and accentuating those stretch receptors.
I had no idea that this surgery actually changed the hormones.
Yeah.
And the bad hormones are the ones that say, we're freaking out, we're hungry,
Mm-hmm.
and then the other ones that say we're satiated. That is so cool. You explained it so
Oh, good.
perfectly. Andrea, when did you realize that bariatric surgery was something that you should explore? I'd love to hear your story.
Um, After a number of years working with Dr. Cooper and being on medications, I think at that point I was on Victoza, and I sort of had plateaued at a certain point. We thought, okay, and we had talked about it for a number of years. And I was like, well, let's see, let's see. And we're like, I think it's time. I I actually was the one who said, "I think it's time." And so I started figuring out where I could do the surgery, how my insurance would pay for it, which you do have to go through a lot of I will tell you, you do have to go through some hoops to get your insurance to pay for it. It is not the easiest. It's not like bing, bang, boom, insurance pays for it. You have to have proof of why you need it. And then there are different steps you have to go through even after your insurance says, okay, um, you have to go through I had to go through a psychiatric evaluation, which was actually kind of ridiculous. It was like one thing where they said, "Do you think this will be a miracle?" And I said, "No." And that was kind of the end of the psychiatric evaluation. I mean, there were a couple of more
You
things to it, but
passed.
it really was like, it was basically like, do you, do you think you, I said, no, I will not be a fashion model. And that was kind of the end of that. And then, but I did have to go through 6 months, I think it was 6 months almost, of nutritional counseling where they had to prove that the diet, like a diet was going to work or something. And the nutritional counseling, as Dr. Cooper knows, because I would report back, was really BS. I mean, the nutritionist was like all the nutritionists I've ever been to. Oh, here's the diet that you should go on, and you should eat this plastic cheese, and you should eat this low calorie this and this. I mean, she was very nice. And then they would report back my weight every week. And I mean, it was, I mostly asked her about her family in Long Island and like, because it was just so I mean, it was really not productive.
Yeah.
And I mean, I was still doing my other things that I always did before, and the weight really wasn't coming off, um, because it just wasn't gonna come off anyway.
So what exactly was the surgery and what happened?
So, the surgery was a gastric sleeve. I have to say it was the easiest thing ever. I have not had a lot of surgeries, so I don't know what to compare it to really. But everyone, I did it at USC here in Los Angeles. My surgeon was very nice, not very well informed about metabolism, I will say, but he was super nice. And everyone at USC who was involved um, in that area, because basically all they did was a lot of gastric sleeve surgeries, I guess, in that area, could not have been nicer. They couldn't have been better people. And when they went in for the surgery, they also found a big hiatal hernia that they fixed. So I don't have acid reflux anymore. I don't take any acid reflux medicine.
Wow.
Um, and as a result, we did think that I could lessen a lot of my medications, which because I have like a lot of other issues, I am back on all my medications, but it was the greatest thing I've ever done. The recovery was super simple. It was like a week of sort of not running around a lot, and then sort of liquidy type of foods for about a month to sort of get my stomach back into shape. You sort of eat mushy stuff
Mhm.
for about a month, I think it was. And then back to eating regular food. You slowly go back onto eating regular food. And I would say that because I have a smaller stomach, I do eat obviously less food than I ate before, probably. Um, and then in combination with, I take Manjaro now, not Magumbo as I used to call it, but I take that. So I eat lots of little meals all day long. And my my brain doesn't think of food all the time, although I have a very powerful food brain, so I do think of food a lot. But I want to eat a lot of things, but I only eat little bits of food all the time. And at first, I would say my stomach could only handle about 4 ounces of food at a time. Now it's probably about six, maybe 6 to 7 ounces per meal ish. And what people don't think about is you don't drink, like a lot of people drink water or whatever when they eat. That counts in the food that you eat. So you don't, like when I eat food, I don't usually drink at the same time because that counts as in the quantity.
Hmm.
And so that you just get used to.
So Andrea, compare what eating felt like before you had the surgery to once you fully recovered. What was that process? What did it feel like?
Um, During the recovery time, it was weird because I kind of ate pudding and soup. But
No, but I mean
after,
just the experience of eating. Like the experience of eating. When you ate before, did you feel full and then
I, f-
just
I had been on Victoza for a while, so I
Mhm.
felt full like instantly when I was on that drug. Now I feel full with a lot less food.
Yeah.
Um, and I eat a lot more times a day, but I had already been starting to get used to that. And now it's just with less food, and everyone makes fun of me even more because I love food and always will. I grew up in a food loving family, a food loving environment. So I just take home more food because I like to order everything, and I just still do. I order everything. I just eat less. Everybody else has to eat more or not. I don't care. And I'm fine with it.
Mhm.
I'm fine with the way everything is. And the weight has come off slower than, of course, I would like, because I would love to be the miracle girl holding up the big fat pants. But the good thing is, unlike when I've done 800 million, whatever million diets, the weight has stayed off. And I don't find it hard. Whereas before, it was always, I felt like it was a war and it was a battle and it was a long term thing and it was agony. Now it's just life. It's not a big deal. I don't feel defeated. I don't feel like something is working against me. I feel just like I can go through life. There's nothing weighing on my shoulders. There's not this big thing weighing on me. I just do what I want to do.
Yeah. Dr. Cooper, I'm sure more than a few people listening are thinking, maybe I should consider bariatric surgery. How does someone know that this might be an option to pursue?
Well, I think there's certain criteria. So the pharmacology approach, with not dieting, fueling your body well, getting enough sleep, doing all the lifestyle strategies that we talked about to keep your metabolism healthy as a foundation are important. But then looking at the pharmacology and what would make sense based on your metabolic system. And Andrea mentioned one medicine that she was on, but there were others too that were addressing other aspects of the metabolic dysfunction as well. And
Oh,
so
yeah.
you want to make sure that it's very unlikely that there's a single medicine that's going to correct like all the metabolic problems somebody has. Even with today's medications, it's getting closer to being maybe a single medication that could be powerful enough, but I don't think it's quite there yet. But exploring the pharmacology, and then once we have patients on the pharmacology, there's different groups. There's people where they're making steady improvements and things are really looking good on a continuing basis, and we're getting to points where we can start maybe potentially tapering certain medications and everything is looking stable. Of course, that group would not need bariatric surgery. And then there's another group where you have to have a pretty large cocktail of pharmacology to address all the metabolic dysfunction. And you have to weigh that with the progress that you're making. Is this something sustainable to be on that type of pharmacology over a long period of time that it's taking to kind of get to a point where the metabolism improvements are strong enough, to justify that degree of pharmacology. And it may be that it is fine, but it may be that that person could be considered for a bariatric procedure, or we should call it a metabolic surgery, to help kind of boost their metabolic function to a level where their pharmacology need becomes less. And so it could also be that the patient doesn't tolerate pharmacology. So a lot of the medications can have side effects that might be hard to tolerate for certain patients, and they might be better off proceeding, with a metabolic procedure that makes their pharmacology burden a lot less. Um, there's also patients where they're on the verge of uncontrolled diabetes, or they're dealing with significant fatty liver disease or other things that put them at really more long-term risk, and you don't have 5 years to reduce this risk. And so you start looking at, look, because you're in this critical health state, we need all the help we can get as soon as we can. So let's combine the benefits of these metabolic surgeries with the pharmacology. But I think what you need to think about too is any kind of surgery does carry risks. I mean, not just in the
Hmm.
immediate aftermath of the surgical procedure, but when they look out like 8 to 10 years, there is an increase in complications after surgery. And so, nothing necessarily horrible, but it's just that you have to consider these things. And so, What we really want to do nowadays is look at our newer pharmacology that's coming on the market, some that's there now, some that's in trials that will be coming out over the next year or two, that literally can mimic the benefits of the metabolic surgery. That can come very close. And so you kind of want to take these patients and see, have you given them enough chance with the pharmacology avoiding a more invasive procedure? So it's not something we jump to. Of course, not everyone's going to have these metabolic surgeries. It should be people that really need it. And as Andrea said,
Right.
she was in a situation where we had made a lot of progress, but we're kind of at a standstill, and we really wanted to make further progress. Otherwise, we weren't going to be able to get to a point where we could reduce the pharmacology load that she was on.
Hmm.
And so
Right.
this was like taking a huge dose of medication and throw that in the mix in order to see how that helped alleviate some of the other dependency on medication.
Right. I mean, and I'm still working on
Yeah,
it. It's not
sure.
like, oh, this was the total
No.
answer. We're done. Bing, bang, boom. Everything's perfect. No, it's still what they call a process.
You're not a Kardashian yet.
No, nor do I want to be,
I'm kidding.
but
I'm kidding. I was just
although I
using
wouldn't
your
mind their
line.
money. I wouldn't mind the money,
That would be
but
nice.
I think that's a misunderstanding about bariatric surgery or metabolic surgery, is that it's immediate results, as Andrea said, and it's one and done. But when you're talking about a person who has metabolic dysfunction that caused obesity or diabetes or other disease risks that are combined with that metabolic syndrome, to having a metabolic procedure such as the VSG, which is also called the gastric sleeve, or the gastric bypass, that is not, that doesn't completely reverse the underlying problems. It is great in the short term and even in the long term. I mean, the data on these surgeries is very robust. We've been studying this for so many years, and we have excellent data to show the benefits over time. But the primary weight loss period is within the first year and a half. And then the weight normally plateaus and starts to climb back up. Most people do not regain all the weight they lost, but some people do regain all the weight they lost. And some people end up higher than their starting weight. It's not common, but it can happen. And I've met patients that happened to, and it's pretty sad for them.
Wow.
But I think
Yeah.
people are not counseled prior to surgery to explain that this is normal. And so we get a lot of patients in that think, oh my gosh, what's happening? I've regained this weight. And when we do the calculations, they're actually doing better than what the research shows. So they're surprised to hear that, because no one told them that there'll be this initial weight loss over the first year and a half. It will most likely plateau and then start increasing. And so it would, again, just like the counseling before diets, it should be really discussed with patients. But the good news is that we, by combining these surgeries with the pharmacology for the toughest cases that we see, can be just life changing for people and can be a great option.
Andrea, how many years ago did you have your surgery?
I think I had it in 2020,
Hmm.
so it's 3 years.
Yeah. And you're happy, absolutely happy with it.
So happy. So happy. And I mean, I'm one of the lucky ones that my weight has gone, it definitely has gone down.
Hmm.
But I will say that the weight has gone down because, I mean, this is sounding like a commercial for Dr. Cooper, but it's gone down because I was working with Dr. Cooper, not because I just did the bariatric surgery and
Yeah.
followed the diet plan of the low fat cheese. It didn't go down because of that. It went down because I followed a program of pharmacology
Yeah.
and, um, doing it that way. I couldn't do it without all of that. I couldn't. It wouldn't have
Hmm.
happened because we tried, like in the beginning, you sort of have to be free of all of that to see what's going on. And I had I guess because I had 50 years of damage done, it wasn't gonna work.
Right.
Uh,
That's the customary thing is before the surgery, you stop all your medication pretty much. Even for people with diabetes, they normally stop most, if not all, of their medication.
yeah,
And then you kind of wait to see what happens because these metabolic procedures can have such powerful impact that you don't want to be over medicated. And so we usually check lab work about 6 weeks after the procedure for the first time, and then again a couple months later. And a lot of patients don't really need to start adding back any type of pharmacology for at least a year. But sometimes it's different. Sometimes you can see right away that you're going to need some assistance from a medical treatment approach.
Dr. Cooper, do you think advances are going to continue to be made when it comes to this type of surgery?
Yes, I do. And in fact, there are some current advances where they now have a procedure that's done through an endoscope. So it tries to mimic the sleeve, the gastric sleeve, but without surgery. So it's a much less invasive procedure where they put the scope down as if they're looking to see if you have ulcers in your stomach, kind of same type of procedure. And they insert some anchors in your stomach and run a stitch through that and basically seam it, create a seam in there internally without cutting anything. And so they shrink the size of the stomach in the same fashion that they would through this laparoscopic surgery. The one downside of that is that it's not eliminating the portion of the stomach where the ghrelin is manufactured. So they don't really know long term what happens. The research shows definite benefit from that procedure, but not as powerful as the gastric sleeve. And then again, we don't have a lot of really robust long term data to know whether how strong that is. And I don't have too many patients who've had that procedure,
Hmm.
but there are other things like devices that we don't recommend that are kind of like balloons that they put in your stomach.
I've heard of
Yeah,
those exploding.
yes, they can explode. And there's just all kinds of stuff. And so I think that the VSG gastric sleeve procedure is just so good because it carries very low risk as a surgery and low long term complications, and the improvements in all of those risk factors for cardiovascular disease, fatty liver disease, diabetes. I mean, it's a pretty strong argument, for those surgeries if you're going to have a procedure. But again, we don't necessarily want to do an invasive procedure if we don't need to. And so you definitely want to find out more about what is the metabolic problem that's going on, what's the best treatment for it. Do these trials to see if you can reverse some of that dysfunction and enough of it to not have to uh, pursue a surgery.
Do the doctors that do these surgeries, do they prescribe like a low carb or low calorie diet for their patients? It seems sort of counterintuitive. Andrea, what did they tell you? How did
Oh
they
yeah.
tell you to eat?
Oh,
Really?
it was low carb,
Wow.
low everything. Low, 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 low.
Wow.
Um, really low calorie and not great.
And that, Dr. Cooper, that just kind of defeats the
It
purpose,
does. We
right?
had to hijack Andrea to take her away from, to bring her back to our dietitian.
Oh,
Yeah,
my
I would
goodness.
it was I felt like I was a secret spy because I would take all the handouts. You got a lot of handouts, a lot of
Yeah.
like I got a lot of pamphlets and a lot of handouts, and I would send them to Dr. Cooper's nutritionist. I'd go, "Look what they're telling me now. Look what they're telling me now." And she's like, "No, no, 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 no,
Yeah.
no, no."
I know it's
Wow.
just the
Yeah.
mentality in the medical field, whether it's surgery or field of medicine, to prescribe diets, to prescribe low carb, to prescribe high protein and calorie restriction and exercise on top of it. And
Mhm.
again, if you look at my patient base, the number of patients I've had that have come in that have had bariatric surgery and are doing all those things and are gaining weight rapidly and feeling terrible. I mean, it's just, it's just rampant. So it, there's really, I think that, I don't know why we keep gravitating to this diet strategy when there's really no evidence ever that it ever worked long term. There's no
Yeah.
evidence, none.
Yeah. Dr. Cooper, even her nutritionist that I've worked with, who I love and is the only nutritionist actually that I've ever worked with who's prescribed real food, she even changed the brand of protein drink that they prescribed in the thing. She was like, no, that one is all like fake junk. No, you can't have that. No, don't eat that. It was kind of amazing.
Yeah.
Well, this has been a really interesting conversation. I've learned so much just about what the bariatric surgery or metabolic surgery actually does to the body. And I guess the big takeaway, Dr. Cooper, is that this should be considered as just another tool for some people under some circumstances,
It
right?
really should. And it's actually interesting to consider that we probably shouldn't be using obesity as a requirement for the surgery either, because there are
Hmm.
people that would benefit that don't have obesity because of the strong metabolic benefits of the surgery. So if you had someone with metabolic syndrome that was really strong, but they had a pretty normal weight or close to a normal weight and not in the obesity category, they too could potentially benefit if they have diabetes or cardiovascular risk, fatty liver. So the idea that we're limiting these surgeries to people that have obesity is kind of not really the correct thinking, I feel. Same thing with some of the pharmacology that we have. We shouldn't be thinking of it as body weight, because body weight is just one symptom. It isn't
Hmm.
always there for everyone. There can be people that have significant metabolic disease without high body weight. And so they also should be considered, for the more aggressive treatments.
Do insurance companies require obesity before they'll
They
cover?
do. In our country, they
Because,
do. I've heard
yeah.
that some parts of Europe, they do. They do these surgeries for diabetes, patients with
Hmm.
diabetes, regardless of weight. So, but in our country, it is strictly by BMI. The BMI requirements for surgery have come down some. Um, and so that makes it a little bit more accessible. But it is interesting
Hmm.
our thinking about weight and not seeing it as a symptom of metabolic disease, and that some people genetically are prone to that, but others are not, and they're prone to other metabolic dysfunctions such as fatty liver or diabetes. Or
Well, this has been really interesting. Thank you so much, Dr. Emily Cooper, Andrea Taylor. This has been another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper, a Work P2P production. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.